So I'm trying to be brief, but please feel free to ask me any question any moment you may want. Okay? So I wanted to take this opportunity to share with you our regional program in Central America and Mexico still have an idea there, and our HIV program that is called Population Prevention HIV. And I wanted to start just to mention to you that this program responds to a partnership framework that was signed between the government of the United States and the governments in Central America. This agreement was signed like 2 years ago, and basically they defined together 4 main objectives where the governments from Central America were asking support. So this is important because it's not the United States saying we need to work on this and this and that, but the government saying where they need support. And the partnership framework basically has 4 main objectives. One is about behavior change activities, working directly with MARPs, most-at-risk populations and people living with AIDS. The second one is about improving health systems. The third one is about streaming information and everything that is related to research or research dissemination. And the last one is about policies. Our program responds to these 3 first objectives. We don't actually, in the program, work on policies, but we work close with the other partners. And something important is that all the USG agencies, that means CDC, Department of Defense, Peace Corps, and USAID, work together making sure that all partner implementers don't duplicate efforts responding to this objective. So based on this, we developed our combination prevention program, and it started in October 2010. It's a 5-year program. It's implemented, the prime recipient is PSI, and it's implemented by PASMO in Central America, and PSI in Mexico, in Mexico. In Costa Rica, just for you to know, we are not called PASMO, we are called PSI, but doesn't mean Population Services International, but Proyecto de Salud Integral. And those things are more how we are registered, but at the end we are the same. We have 3 main program implementers, partners in the region that are IPPF, Chicateria Associates, and Milk and Cookies. Milk and Cookies is the first private partner we have in the region, and their area of expertise is social media. That is all the innovative program, area that we have in the program. And of course, we work with other key players that are important on local ministries of health, national aid programs. We work with the private sector, and that is something key in this program, to include the private sector, with NGOs and civil society, and still with some FBOs. So our program has 4 main results that I'll try to summarize. The first one works on all the behavior change activities and working directly with MARPs. The result 2 works, and our objective is to create a more respectful environment, and this is the result where we work on the stigma, discrimination, and homophobia efforts. On the result 3, we have everything that is related to access to products, and all condom and lubricant distribution is here, but also access to services. Working with the private sector, with the IPPF clinics in the region, among others. And on the result 4, we have the strategic information. Basically, it's everything, monitoring and evaluation, all the big list, the agenda we have in the region, plus everything that is related to research dissemination and application of data. And we have redefined our target populations, and we have like 3 levels, priority levels. The first one is working with people living with AIDS and transgender populations. At a second level, we have men that have sex with men and female sex workers. And at a third level, we have men at risk and Caribbean population. Originally, in the program, these 4 were the main populations. But we decided to have different levels because Global Fund is working hard with MSM and sex workers, and we don't want to duplicate, so we changed priorities. Important to note that men at risk originally it can be understood like general population, men and general population. So we decided to define them based on their occupation. So there are some occupations that put men more at risk, like all this mobile population, truckers, bus riders, taxi drivers, construction workers, etc. And in Caribbean population, well, in Guatemala we have Garifunas, in Panama we have Punas, there are indigenous population, and a small portion of mosquitoes in Nicaragua. Okay, the strategy of our program is based on the socio-ecological model, and here you can see the four results that I just mentioned, how they work together, making sure that we work at different levels. We work directly with the individual, we work with with family and friends, but also with organizations and the health system, community and society. So that's why this is a more integrated program. It is important to know that this program is not completely new, because we have been implementing and working on HIV since 10 years ago. And previous program is not completely different from this, because in the past we still used to do BCC activities, BCT, condom distribution, different actions, but in the way that I explained this is that they were separated. This program is trying to integrate more them following a combination prevention strategy. And this is the way we define it. If you read the first paragraph, is basically the theory, what is combination prevention. And basically we can see there are three main components: behavior, structure, and biomedical. And that sounds very good, but when after we get the award, the challenge was how we are going to implement this in the field. So the first thing we did is that we developed a minimum package per target population. And the minimum package is divided in three components: the behavioral, or the basic component, and this includes BCC, all the behavior change communication activities we do using the different methodologies, participative, one-on-one, and the different activities we have been doing by target population that respond to the bubbles and the track and all that. And also includes access and promotion of water-based lubricants and latex condoms. That this is something also ongoing. We distribute Vive condoms, and that is ongoing. The biomedical component includes basically includes BCT referrals and with pre and post counseling, and STI diagnosis and screening. And for people living with AIDS, we have defined or identified other referrals. Basically, it's STI diagnosis and treatment, and referrals to health services, ART programs, diagnosis of opportunistic infections, among others. And the complementary component, that's really the new one under our approach, that is working or identifying other services that that our target populations may need and that may be helpful to improve their lives. So also by target population, we have identified different and varies country by country. But I can mention family planning, reproductive health services for female sex workers, but also for men. Referrals to support groups, and here we already have some coordination with stigma and discrimination, legal support, violence, nutrition for people living with AIDS, referrals to alcohol and drug treatment centers, right, as an example. So, like responding to these three components, we developed the minimum package, tailored by target group. So this is an example that I already mentioned to you, but in behavior we have the IPC, so we can we develop materials and methodologies, and we implement this type of the current methodologies we have in the region and the distribution. And we want every individual at least to pass for 3 activities, 3 BCC activities and condom and lubricant information and the biomedical, I already mentioned that, and the structure. So now we also are talking in the region about combined individuals, because it's not that we reach different people, but we want combined individuals, and that means a person that has closed the cycle of the minimum package, that for us is combination prevention. So this is an example on how, because that is still theory, no? Sounds good, but then how are we going to do that in the field? So this is an example of one of the activities we're implementing right now. And we created HIV tactical prevention teams to implement sweeping the zone activities. These HIV tactical prevention teams are formed by a BCC team leader, usually from PASMO, the educators, usually from NGOs, sales staff, and this is new because in the past, both departments used to work separately, now we're working together. So sales is part of the tactical team, the BCT staff, that is not only our own staff, but IPPF or the member associations, doctors, nurses, and staff, and in some countries, the MOH, the public sector. Complementary services partners, and these are the ones that we are identifying country by country, are part of the tactical teams. And for the first time, we are introducing a new field that they are called cyber educators. So I'm going to talk more about cyber educators a little bit later. All of them are part or conform the tactical prevention teams. So once we have that team conformed, we have mapped the hot zones that there are in each country where we know our target populations gather and meet. And so we go to this hot zone and we create bus in a hot zone working all together. So NGOs, educators are implementing BCC, BCT are doing pre and post counseling, the clinic are closed there. In some cases, in some others are mobile clinics or where they can receive the test and pass through all that biomedical service. And the complementary partners sometimes put kiosks or also have information available there. So that's why we sweep the zone. And these activities can vary depending on the size of the hot zone. In some countries, we are there like for a week, working during the mornings, or in some other hot zones that are smaller, we can just go one day. So it depends on the country, the target population. But that's the way we are like sweeping this one. So that's how we are implementing this. But we also needed to measure access to the minimum package and be able to report individuals because we need to count them. So to do that, in order to do that, we came up with the unique identifier code. And there's background about this. We studied and received the report that because PSI had implemented the UIC in Asia, but with other target population, with drug users, but we revised how they have done it, the results, the findings, and based on that, we developed our own. We piloted during the first year in Belize and Guatemala, and the rollout in Central America started in October last year. So right now, all countries are collecting the UIC and how it works. The UIC is a system that allows a program to know how many interventions a person has participated in which interventions that a person has participated in. And this is important because these are some of the indicators we have to report to USAID. So the characteristics of our UIC are based on personal information, is confidential, and that is important, and maintains the anonymous, you can say like that, or it's anonymous, so we don't want to identify anyone. It's information that doesn't vary over time, so we wanted to make sure that people was always going to report the same information. Gender and age are provided. At the UIC, we can get the gender and age because it's something also that we need to report. And in general, we have margin of error of around 2%. We took into consideration literacy, sensitive to paternity, and the use of different names, especially with trans, because they used to change name very often. So after analyzing and processing all this, we came up with our UIC that is of 7 digits. And it's like that. The first 2 letters of our last name, gender identity, male, female, or trans, the first 2 digits, the birthday, and the birth year, the last 2 digits. And in some cases, like in Belize, because the government is already using the UIC, they have asked us to add 2 more digits, and they asked geographic area and if it was urban or rural. So that is something good of the UIC is that is flexible, and we can, if a country has a need, we can just add it or discuss it. So the advantages is that we can know the total number of persons reached by the program. At least it's more realistic than our previous formula that was really very estimated. We know if each individual has been exposed to more than one prevention message, and that's important because we want that the individuals will reach close the cycle of the combination prevention. So we need to know, we can know if a person has already been reached with the 3 BCC activities, with the condom activity, with the biomedical and the complementary. So in that way we can say how many combined individuals we have. We know the total number of individuals reaching the country and region because we develop a system to track this. It's called SAM, and it has different modules, the behavior model, according to the minimum package, the basic component, the biomedical component, and the complementary component. And in the future, we think we will be able to track and know if a person has migrated from one place to another. We are already finding this internally, so we have found some UICs in the capital city and in the interior, and we have tried to confirm that, and it's true because in some cases there are truckers that have been reached by an NGO in the city and then in another city. But in the future we will be able to see that also across the region. So that's the UIC, but how we're going to be able to make sure that educators and NGOs and all our partners were going to understand and collect it. So we developed a referral system, a voucher referral system. That is, it consists in a pack of 6 vouchers of different colors that are these ones. So we have 4 for the behavioral or the basic components that are the red ones. 3 are for the 3 BCC activities that are part of our minimum package, and 1 is for the condom or lubricants activity. The green one is for the biomedical service, and the blue one is for the complementary service. So the colors identify the components. We are able to know what target population is because we have here some figures, and like squares, triangles, circles. So we know that a square is sex worker, that a triangle is MSM, but people don't know because we don't want to identify themselves. There we have series of sequential numbers just to track them and make sure that the track is completed. But the most important thing is that the voucher collects the UIC. And all these, because our educators also have monitoring forms. But they collect the vouchers, they enter the UIC into the system, and they compare the UICs with the voucher received, so we are able to track. In the near future, we think that the vouchers will disappear because basically they are being useful right now for us to change the chip, the way that I say it, because NGOs have been able to understand using this that combination prevention is a series of activities and not just one IPC intervention. And well, the green voucher also has a use because that's your ticket for free, to receiving some services for free with our partners. But yeah, this is the way we are collecting this and supporting the introduction of this new approach. And this is the way basically it works. So we have PASMO, or the NGO, when we reach a person, we give them the pack of the 6 vouchers, and we make sure that every time we collect or we take one voucher is because the person has received that intervention. And then the NGO, the educators or PASMO collects the vouchers in with the providers, in the case of the biomedical and the complementary. We enter that into the database, into SAM, our system, and we start like on the analysis, and this is like a continual process. And some significant accomplishments. These are results of the last 6 months of this new fiscal year 2. We have reached